Greetings. Once you have diagnosed that the patient has ascites and either moderate or severe ascites that is uh, found on clinical exam, you could consider doing an ascitic tap to make a diagnosis. So let us learn about how to analyze the ascitic fluid. I want to thank many who support this program, and please read this notice. So, the most common cause of ascites is cirrhosis of liver due to portal hypertension. You could also find ascites in severe congestive cardiac failure, and portal hypertension, whether it is cirrhosis or heart failure. uh, Ascitic fluid analysis reveals an increased serum ascites albumin gradient, more than 1.1. Another reason for ascites is peritoneal irritation, either from cancer or tuberculosis. In this case, the serum ascites albumin gradient is less than 1.1. So if you learn this concept, then you need to learn how do we calculate or measure serum ascites albumin gradient. It requires an ascitic tap, and when it comes to ascitic tap, uh, you need to understand a couple of things. Where do you do the tap? The best place to tap is the left lower quadrant, about 2 finger breadths above the iliac crest and slightly medial to the iliac crest. 2 finger breadths above and 2 finger breadths to the medial. Uh, so the left lower quadrant is preferred, not the right lower quadrant, because right lower quadrant, if there is an appendectomy scar, yeah, it's risky to do that there because of bowel adhesion. And if the cecum is loaded with stool, then you can puncture the cecum. So the site of choice is the left lower quadrant. The next is, how do you uh, make an ascitic tap? You can take either a 22 gauge needle or 23 gauge needle. After applying a little bit of local anesthetic to the skin, following skin disinfection with powdered iodine or chlorhexidine, one of the solutions that is preferred by the institution. And then, after local anesthetic to the subcutaneous tissue, you try to create a Z-track by trying to apply pressure and pull the skin towards you and then puncturing so that when you release the skin, it forms a Z-track and prevents from ascitic leak. That's important to keep in mind. So you need to take about 10 cc's of ascitic fluid, and this is how we make the ascitic tap. This going at an angle, puncturing the skin at one point, subcutaneous tissue at a different point, and the peritoneal cavity entry point is at a different level. And when you take the needle out, then it forms a nice seal. So in order to do that, you have to try to pull the skin down and then go at a point at an angle so that you avoid ascitic leak down the road, especially in patients with severe ascites. There is a lot of literature now to support that it is very safe to do ascitic tap even when the platelet count is below 50. There are reports of safe puncture in a large number of patients to as low as 30,000. And also, even when the INR is high, 1.5, 2.5, in some cases they have reported to very high levels, it is safe to do an ascitic tap. You don't need to give platelets. You don't need to do a correction of the INR before the ascitic tap, unless there is a DIC. So what do you collect? For all patients with cirrhosis, you start with basically two things. Collect a vial for ascitic fluid albumin and protein, and another vial for cell count. At the same time, on the day when you do your ascitic tap, it's also important to collect the blood for serum albumin. So, serum albumin, ascitic fluid albumin, and ascitic fluid protein and cell count. So now let us talk about how do you calculate serum ascites albumin gradient, or SAAG. So let us do a little bit of calculation using a hypothetical case. So here is a patient. You take the blood draw and the serum albumin is 3.5 grams. And the same day, the ascitic fluid albumin is 2.6 grams per deciliter. So if you subtract 2.6 from 3.5, it is a value of 0.9. That is the serum ascites albumin gradient. So we know from extensive work that a serum ascites albumin gradient, the cutoff is 1.1. If the serum ascites albumin gradient is less than 1.1, you can safely say this is unlikely to be portal hypertension, and most likely to be due to peritoneal disease, peritoneal inflammation. The inflamed tissue is losing not only fluid but proteins. That's why you don't have a high gradient, you have a low gradient. And you should be looking for cancer and also tuberculosis. So serum ascites albumin gradient of less than 1.1, peritoneal disease. So let us take another example. Here is the serum albumin of 3.5, ascitic fluid albumin of 1 gram, and the difference is 2.5. The serum ascites albumin gradient is 2.5. High gradient above 1.1 indicates portal hypertension. So the first step in ascites evaluation is calculation of the serum ascites albumin gradient. If it is less than 1.1, you know it's peritoneal disease. You look for cancer. You may send the cytology, fluid for cytology. If you think there's a suspicion of tuberculosis, you can send it for AFB and ADA levels. On the other hand, if the serum ascites albumin gradient is more than 1.1, then looking at the ascitic fluid protein may help whether the ascites formed because of portal hypertension is post-sinusoidal obstruction or sinusoidal obstruction of the liver. Post-sinusoidal obstruction of the liver, that means in the hepatic veins, IVC, and right heart. So if the serum ascites albumin gradient is more than 1.1 and the ascitic fluid protein is more than 2.5 grams per deciliter, it indicates post-sinusoidal portal hypertension. Classic examples are heart failure and hepatic outflow obstruction or venous outflow obstruction or Budd-Chiari syndrome. On the other hand, if the ascitic fluid protein is less than 2.5 grams with a high SAAG, that is indicative of sinusoidal portal hypertension. Classic example is cirrhosis of liver. So for the most part, you want to calculate the SAAG, and you can figure out if the SAAG is high. Obviously, you should be thinking about heart failure, cirrhosis of liver, and anything in between that is hepatic outflow obstruction. And you could find out by clinical exam, heart failure, no heart failure, by looking at signs of right heart failure signs. So in addition to, and then if you need to, sometimes if the protein is high and you're thinking about cirrhosis, then you should be thinking, hey, ascitic fluid protein is high, SAG is high, maybe it is not cirrhosis, maybe it's post-sinusoidal portal hypertension. Let's make sure we get a cardiologist involved, make sure we evaluate the hepatic venous outflow a little more carefully. So now we talked about how to make a diagnosis based on the fluid analysis. And every time you take fluid out of a cirrhotic patient, you should check whether there is infection or spontaneous bacterial peritonitis. This could be asymptomatic. If the patient comes in admitted, you should check it. If the patient comes in with a bleed, you should check it. If the patient shows any worsening liver function or renal function or mental function, you should check the ascitic fluid for cell count. So, what do? Well, once you take the fluid, you send it for cell count, and the lab looks at it under the microscope and gives you a number of the polymorphonuclear cells. And if the count is above 250 per ml, then you diagnose spontaneous bacterial peritonitis or SBP. So let us summarize what we've learned. When you do ascitic tap, you do check the serum ascites albumin gradient, look at the ascitic fluid protein, and also look at the polymorphonuclear cells. If the SAG is high, portal hypertension. If the SAG is low, less than 1.1, it excludes portal hypertension. You should be thinking about peritoneal irritation, cancer, tuberculosis. If the protein in the ascitic fluid is high, you should be thinking about heart failure and hepatic venous outflow obstruction. If it is less than 2.5, cirrhosis of liver. And when you look at the PMN or polymorphonuclear cell count, if it is more than 250, think about spontaneous bacterial peritonitis. So this concept is very important. And it's also important to think about ascitic tap the moment the patient gets admitted. And if the patient has SBP, you should treat promptly. And delay in diagnosis can impact on the patient's survival, especially any patient coming into the hospital. I hope this is helpful. And finally, when you think about spontaneous bacterial peritonitis, you should also send cultures and by taking the fluid and inoculating at the bedside. I want to thank authors of this fantastic guideline. And this is what I've used to prepare this presentation. Thank you.